We are happy to present OmniFlow, which is a novel GDD, a valve tube shunt, to drain aqueous humor from anterior chamber to the retrobulbar space. A micro valve tube pressure regulator is fitted inside a soft silicone tube which controls the outflow of the aqueous humor, which will prevent hypotony and maintain the IOP between 10 and 24/7 without or with minimum number of topical anti-glaucoma medications. This is how the OmniFlow tubes look. This is the anterior chamber end, this is the retrobulbar end, and the tiny pressure regulator is inside the tube. Retrobulbar space behind the equator is almost free from myofibroblasts, hence it is virtually free from fibrosis, even without mitomycin C. Retrobulbar space can easily drain up to 500 microliters per minute without engorgement, proptosis, or chemosis. Aqueous humor production and outflow discharge rate is only 3 microliters per minute. Hence, retrobulbar space can easily drain 170 times more fluid than the aqueous humor production. Let us see few videos of OmniFlow. After putting L cut in the conjunctiva and after a little blunt dissection, insert a vectis to reach the retrobulbar space, which is very easy. We can insert almost 40 mm of vectis which goes into the retrobulbar space and creates a track. A gentle bipolar cautery is done. Now we make one scleral tunnel which is made by angled MVR 20 gauge 7 mm away from the limbus at 45-degree angle. The tunnel is now lubricated with viscomethyl. The beveled end of OmniFlow is now inserted in and passed through the scleral tunnel. Three-fourths length of the tube is pulled out. The valved end of the OmniFlow tube is inserted into the retrobulbar space. It goes quite easily as if a rope is falling into the well. The excess length of the tube is pulled back and pushed into the retrobulbar space. Now a second scleral tunnel is made which is radial or perpendicular to the limbus, about 2 to 2.5 millimeters from behind the limbus, which is then entered into the anterior chamber, bisecting the angle between the endothelium and the iris. The beveled end of the tube is now inserted into the anterior chamber via the second scleral tunnel. Only the bevel goes into the anterior chamber about a millimeter or 2, maximum 2 millimeters. Then the excess bend of the tube is pulled back and which is then pushed back into the retrobulbar space. The firm anchoring of the tube is confirmed by vigorous pull, push and sideward movements, and as we can notice here, no matter how much we nudge, the tube will not budge. The tube cannot be pulled out unless we want to pull it out. It's firmly anchored, it's not going to migrate, it's not going to move on its own. Now we put fibrin glue and the conjunctiva is reposited back. The entire surgery for this is sutureless and it takes only about 10 minutes to do the surgery. Hypotony, never. So hypotonic choroidal effusions, never. Hypotonic maculopathy, never. Silicone oil induced glaucomas, severe rubeotic neovascular glaucomas, multiple failed TRABs, and traumatic angle recession glaucomas are the best indications of OmniFlow, and they are best served by the OmniFlow. In this one-eyed young patient of severe Sturge-Weber syndrome, after 4 failed TRABs, OmniFlow saved the only working eye. OmniFlow tube is not just biocompatible, it is biointegrable. So there is never any tube exposure and there is no need for any patch graft over the tube. Thanks a lot.
What is the thickness of the tube?
It's 0.7 outside lumen and 0.1 is the main lumen. And the Teflon wall is there fitted at the retrobulbar end. So that is 175 to 250 micron. Length is 50 millimeter. So which length to be implanted? So it's axial length plus 5 millimeter. That is the formula.
Okay, and the chances of infection because you are...
No chance.
Because once you are inserting, it's inside the eye, it is open, right? You are in maybe retrobulbar, you are fitting it under the conjunctiva, but inside it is open. When you are putting it inside, so any chances of infection you have seen?
No, we have implanted now all over India. It's more than 1,000 implantation. No, not a single case. No. It's working very well in the most refractory of the open angle glaucomas like the neovascular glaucoma, the silicone oil induced glaucoma, the Sturge-Weber Axenfeld-Rieger syndrome, and even the primary ophthalmos cases. It's working well. And the main advantage is the side effects of trabeculectomy are not there, like the choroidal effusion and detachment.
So size differs in the ophthalmos and all?
No, it's the same. It's the same. And no requirement of mitomycin C because we are exploiting the retrobulbar space that is almost free of the myofibroblast.
Thanks, Dr. Arvind.